Good morning, everybody. Well, it's Friday morning at 11 o'clock, so it can only mean one thing. It's time for the Fralin Biomedical Research Institute Pioneers in Biomedical Research Seminar. So before we have a chance to introduce today's speaker, I want to just make a few comments. Firstly, I want to remind everybody that these are weekly seminar series. So the next one will be next Friday, of course, on September 17th, same time, same station. And at that time, we'll have a seminar that will be jointly sponsored by the Research Institute and also by our Center for Human Neuroscience Research. Dr. Kwabeni Bohan will be speaking. He's a professor of bioengineering at Stanford University at the BioX unit, and he'll be talking about the future of artificial intelligence, a 3D silicon brain. So I hope to see everybody again next week. So today's seminar is jointly sponsored, of course, by the FBRI, but also by the Addiction Recovery Research Center and the Center for Health Behaviors Research. And in that context, before Dr. Witkiewitz is introduced, it is my pleasure to introduce our own Dr. Warren Bickel, the director of both of those centers, who will introduce today's speaker. Warren, take it away.
Thanks, Mike. I am honored to introduce Dr. Katie Witkiewitz. She is an international leader in addiction science. Dr. Witkiewitz is Regents Professor of Psychology and a scientist at the Center on Alcohol, Substance Use, and Addictions at the University of New Mexico. The underlying theme of her research is the examination and treatment of substance use disorder with the emphasis on harm reduction, recovery processes, and applying advanced quantitative research methods to better understand changes in alcohol and drug use behavior over time. Dr. Witkiewitz is also a licensed clinical psychologist and has worked extensively on the development, evaluation, and dissemination of mindful-based relapse prevention for substance use disorder. Her research has been supported by multiple grants from the NIH, totaling over $40 million since 2004. To date, she's authored 6 books, over 260 peer-reviewed publications and book chapters, and is currently editor-in-chief of the Psychology of Addictive Behaviors journal. She's also a field editor for alcoholism and clinical and experimental research. She was recently invited to be a member of NIAAA's council, which is a great honor. Let me just finish by saying that her work has been influential, and she certainly influenced my understanding of recovery and addiction processes. And with that, I am very pleased to introduce you to Dr. Katie Witkiewitz.
Thank you. Thank you so much, Warren and Mike, and thank you all for having me. I really wish I was in person, and we'll settle for this virtual format where we can all still maybe be in pajama bottoms if that's what you're doing. That's great, or have pets around. I've already said that I have my dog here with me, and so if there is some barking, I apologize in advance, but she's my coworker, always at my feet or behind me on my futon. So we'll see if she interrupts us. I'm assuming you can hear me okay. No one's interrupted to say otherwise. So
we can hear you fine.
Great, excellent. Well, thank you so much for having me. I'm actually really disappointed. I looked at pictures of where you are located, and it looks amazing and beautiful. And so I really want to come back at some point when traveling is safe again, because it looks like a beautiful place to be. So I'm going to be talking today about pathways to recovery from alcohol use disorder. The topic seemed really fitting, given that September is National Recovery Month. And so go to nationalrecoverymonth.org if you're interested in programming around recovery. And, you know, I love this tagline that recovery is for everyone, every person, every family, every community. And I hope some of those themes carry through this talk today, and that it can help us think about recovery and recovery in context. And, you know, I should go back to note that I have no conflicts related to this work in particular, but my research has been funded by NIAAA, and most of the work I'll talk about is from our current R01 listed there. So it is National Recovery Month, but I also want to give a shout out to Virginia Tech and the Virginia Tech recovery community. I took a look at your website and your services, and I'm just really impressed with what you're doing to support students in recovery in your community and in supporting people and the recovery community broadly in your community. So just want to give a shout out to that great work that I know Warren's been a leader in, and others, many others there have really helped to make Virginia Tech a place that supports multiple recovery pathways. And so thank you for your work on boots on the ground there. So I'll give an overview of what I'm going to talk about today. I'm going to talk about some of our research on reductions in drinking and clinical trial data. That really has informed kind of new thinking, I think, in the alcohol field and the alcohol treatment field, and particularly new thinking in at NIAAA and at the FDA. I'll then shift to some of our more recent work that has looked at functional outcomes in individuals who experience what I would call recovery but are non-abstinent. And so I'll look at some data on maintenance of non-abstinent recovery as well, and what that might look like. I'll present some new data on social determinants of health and recovery, and then also just have a broader discussion about why expanding definitions of recovery might be helpful for improving public health and also encourage more support for all recovery pathways. So I'm going to be talking about a lot of kind of harm reduction and non-abstinent recovery and aspects of thinking about recovery in a broadened way that might include some drinking. But I really want to start by acknowledging that alcohol is a leading cause of morbidity and preventable mortality. And these are very old data at this point. And in fact, I think it really speaks to how alcohol has not been given the attention as, let's say, the opioid epidemic, that we don't really update these numbers very frequently, but old data would suggest about 100,000 preventable deaths in the United States per year. I bet that's much higher. I think this is grossly underestimated. We know that alcohol is associated with about a fifth of suicide, diabetes, cardiovascular disease, and accidental injury, as well as digestive disease, and then of course is highly implicated in liver disease. So I think it's really important to start with a frame of alcohol is a toxic substance, and in an ideal world, no one would drink, right? And so abstinence would be the preferable outcome for everyone in an ideal world. And maybe there are some shifts happening, and maybe someday alcohol will become like tobacco has become, where it's less socially accepted, it's less available everywhere, it's less promoted on in the media, on TV and movie, and glamorized on TV and movies. But right now we are in a place where alcohol is socially acceptable, it's available everywhere, it's glamorized on TV and the media. And so I think there's this really interesting double bind between knowing that alcohol is toxic and causes morbidity and preventable mortality, but also kind of living in a world where it is socially accepted in many circles. And so this is a tension that I'd be happy to talk more about. It's one I struggle with all the time. But I hope we can all agree that given the known kind of morbidity and mortality, that probably reductions in drinking would still be a good thing. And so that's where I'm going to focus on today. And I'd like to share just a little bit of epidemiological data on alcohol use disorder and alcohol use. And these are some old kind of analyses I quickly ran in the National Survey on Drug Use and Health data from the 2015 survey. And what these data show is that, you know, as I noted, alcohol use is largely socially acceptable in the US. Most people have ever drank alcohol. Most people drink in the past year, majority in the past month, and even a third in have engaged in binge drinking, which is defined as 4 or more drinks for women, 5 or more drinks for men in the past month. But actually, alcohol use disorder and problematic alcohol use is relatively uncommon among those who drink alcohol. And so this is an interesting, I think, point, is that even though a lot of people do engage in drinking, most people actually don't develop problems with alcohol. ever in their lives. And so that's a really, I think, important point that is often missed in kind of thinking about the more severe end. And speaking of the more severe end, if we zoom in on this 11% of people with an alcohol use disorder, and we look at the presence of symptoms endorsed, what we see is that using the DSM-5 definition of alcohol use disorder, where 2 to 3 symptoms is considered a mild case, 4 to 5 moderate, and 6 or more is severe, what we see is that actually in a national epidemiological sample, the majority of individuals with alcohol use disorder do fit into a mild category. So they endorse only 2 to 3 symptoms, another 19% moderate, and then really just a small proportion meet criteria for a severe alcohol use disorder by endorsing 6 or more symptoms. So if we zoom out, that's roughly equates to less than or around 1% of individuals who drink alcohol who would kind of meet criteria for a severe alcohol use disorder. So now I'm going to shift into how that kind of conflicts with how we currently think about alcohol use disorder and treat it in our society. So I think in our treatment models, our research models, and broadly in society and how alcohol use disorder is portrayed, there's still this really one size fits all view of alcohol use disorder, where we really kind of have this image of this individual with a very severe alcohol use disorder. The only way for them to recover is to abstain and never drink again. And we see this in our definitions of recovery. Recovery is defined by the Betty Ford Institute as voluntarily maintaining lifestyle characterized by sobriety, personal health, and citizenship. The Substance Abuse and Mental Health Services Administration defines recovery as overcoming or managing one's disease or symptoms, for example, abstaining from the use of alcohol. I'm currently teaching an undergraduate course in alcohol use disorders, and this week's assignment was, how has the past 2 weeks of the course shifted your perspective? And everyone is saying, I had no idea that alcohol use disorder occurred on a continuum. And I think a lot of people in society, and even some alcohol use disorder treatment researchers and clinicians, really only are working with the severe end of the spectrum, and so not recognizing that there is a continuum of severity. So before we jump into the research, I want to pause to say that achieving recovery through abstinence is commendable and is rightly celebrated as a successful pathway. I have worked with many patients who have chose abstinence for them and have been very successful in abstinence and have built a life worth living with abstinence. And for them, that's the pathway for them, and other pathways maybe were not effective. So individuals I've worked with who've tried moderate drinking and tried reduced drinking, and they actually found all of the decision making that happens when you're trying to reduce your drinking was in some ways harder than making one decision to never drink again. And so I really want to highlight that abstinence is a successful pathway, and I think a very good pathway and a very good choice for most. And kind of hearkening back to the idea that alcohol is toxic and associated with morbidity and mortality, I think it's right that we should be talking about abstinence as one pathway for people. But I also think we should not let perfect be the enemy of the good. And, it's 3 summers ago now, but in COVID times, it all blends together. As I was just talking about with Jeff Stein, how COVID time is very tricky. But 3 summers ago, this Lancet paper came out. Many of you might have seen it. It made big headlines. Any drinking is going to kill you was some of the headlines, because it was a very well done study in some ways. I have some concern about focusing solely on relative risk and other issues, but let's just give it credit for kind of being this very large study that showed in any alcohol use, if we read this graph from left to right, is associated with increased relative risk of mortality. But what I would encourage a different frame in different headlines, which is to actually read this graph from right to left. It's a little bit less sensational, but basically if we read this graph from right to left, the headline would say, any reductions in drinking are associated with reductions in morbidity and mortality. It would have been a very different frame on the same study that actually might have produced even more public health good, I think, in that a lot of people saw these headlines, at least people I speak with, patients I saw at the time, people in the community who I work with, who said, really, any drinking is going to kill me? I don't buy it. But if the headline had been, any reductions in your drinking is going to potentially improve your health, that might have been a very different reaction for individuals. So then the question becomes, and I've been working in an alcohol specialty clinic for many years now, and I also have met with many primary care providers and with psychiatrists who ask me the question, okay, you study harm reduction for drinking, how much reduction is necessary to reduce harm? And that's a really important question, and one that we've been examining recently. And there's kind of a fun story about these World Health Organization risk drinking levels that I'd be happy to share if we have time or in any of the meetings I have later today. But basically, these are risk levels that were published by the World Health Organization that are sex-specific levels of drinking risk correlated with morbidity and mortality. And so the initial World Health Organization levels are in drinks per day, but in grams, which makes sense for the World Health Organization. So I just split it out here into approximate US standard drinks per day and approximate US standard drinks per week. And so what this does is provide a metric for thinking about, okay, if I'm consuming as a woman 0 to 1 drinks a day, I would be low risk, fewer than 10 drinks a week, low risk, according to this metric. If I'm drinking 10 to 20, then that would be medium risk. If I'm drinking 20 to 30, that'd be high risk. And then over 31 would be very high risk. And what's nice about these risk drinking levels is they provide a couple of different features that I think improve upon the previous heavy drinking cutoffs of more than 3 drinks, or 4 or more for women, or 5 or more for men. And I think the way that these risk cutoffs are a little bit more helpful clinically, or how we use them clinically, is we'll sit down and talk with patients and we'll say, here's your current level of drinking, and maybe if they're at the very high risk level. And then we can say, where do you want to be? What do you want your risk level to be? Do you want to be all the way to low risk? Do you want to be medium risk? Where do you want your risk to be? We know that drinking is associated with morbidity and mortality, and we all engage in risk behavior, right? We all engage in certain risk behaviors that increase our risk of morbidity and mortality. We get in cars, we eat French fries, we have extra helpings of dessert. And so what acceptable level of risk is for, or what is an acceptable level of risk for you is a question we'll have I'll talk about with patients. So most people do want to reduce their drinking, and what we have found in many studies now, and I should pause to say that this work is in collaboration with the Alcohol Clinical Trials Initiative, which is a group of academics and NIAAA and FDA and pharmaceutical companies who are coming together to try to understand potential new endpoints for alcohol medications development. And so we've been looking at this endpoint because it's used in the European Medicines Agency as an endpoint for alcohol use disorder clinical trials. And so we've done a lot of research now trying to understand what level of risk is associated with improved outcomes and improved functioning. And I should also say that the World Health Organization, before they published these levels, did not do a lot of validation work. And so these are based on a single cohort study in Australia. And so this work has been really important to us because it's provided actually some great validation of these risk levels, as I will show you. So now we have done many studies showing that, first of all, drinking risk reductions are achievable among those who have alcohol use disorder. So for people treatment seeking and non-treatment seeking. So we've done work in treatment seeking samples, but also in the NESARC data, which is a population-based sample. Debbie Hassan and Justin Knox have led the NESARC studies, and I've led the clinical studies. And what we have found is that about 84% of individuals achieve at least a 1 level reduction in their drinking, and about 68% of individuals achieve at least a 2 level reduction in their drinking. So these drinking risk reductions are achievable in people with alcohol use disorder. So people with alcohol use disorder can reduce their drinking. More importantly, I think what we have shown is that these reductions in drinking risk levels, even short of total abstinence, because we always analyze the data looking at people who make reductions but don't abstain versus people who make reductions including abstainers. And what we have found is that people who reduce their drinking, even short of total abstinence, they also show improvements in systolic blood pressure, cardiovascular disease risk, liver function, mental health, and quality, or improvements in mental health and quality of life. And so again, in both clinical samples and a nationally representative sample, we're showing that these sizable reductions in drinking risk level, even a 1-level reduction, it doesn't even have to be a 2-level reduction. So even a 1-level reduction is associated with these improvements in health and functioning. So then the next question for us became, okay, that's great news. These risk levels appear to be validly associated with improvements in health and functioning, but can people maintain reductions in risk? It's often been a question of the harm reduction controlled drinking literature of whether these reductions in drinking are actually stable over time, or do people just return to very heavy drinking? And so we've done several studies now, but I'll highlight the most recent, which has found that reductions in drinking risk levels, even short of total abstinence, are maintained up to 3 years following treatment. And so this pie graph, very simple presentation of data, shows that of the 84% of people who achieved a 1-level reduction at the end of treatment, 85% of them were still reduced by at least 1 level 3 years later. And similarly, those 68% of individuals who achieved a 2-level reduction at the end of treatment, 78% of them were still reduced by at least 2 levels 3 years later. I don't have the data in this presentation, but we've actually now shown this lasts 7 to 9 years after treatment. So people are able to maintain these reductions in drinking, even if they didn't get all the way to abstinent. So another important point is that these reductions in drinking risk levels short of total abstinence are also associated with improvements up to 3 years following treatment. So these graphs show the clear circles are people who had no drinking risk level reduction at 3 years following treatment. The black filled in circles are drinking risk level reduction, including abstainers, and the gray is drinking risk level reductions, not including abstainers. And what we see for mental health, we see significant improvements in mental health with even a 1-level reduction, but also a 2-level reduction. And we see, again, significant improvements in quality of life, environmental quality of life, and social quality of life up to 3 years following treatment. Another question that we're commonly asked is, what about dependent severity? Clearly, people who are more severely dependent on alcohol can't reduce their drinking. And this is an anecdote and folklore, and there's not a ton of data to support it. I think there is data to support that people who are higher in dependent severity might have greater difficulty reducing their drinking, but not that it's impossible. And these data show that for those individuals who reduce their drinking, regardless of severity, are maintaining that, and that's associated with quality of life. Those individuals who don't reduce their drinking do see decreases in quality of life as dependent severity increases. But for individuals who do reduce their drinking, dependent severity is basically not associated with quality of life, or they have higher quality of life regardless of dependent severity. So this is an important finding that we've found now over and again that dependent severity, individuals can still reduce even if they're high in dependent severity. So I'm going to move now to another lab's work, not my own, but this paper just came out, and I think it's also really important to mention that there may also be recovery of brain volume among those individuals who achieve low risk drinking. In this paper, they looked at just each individual level, and so 1 here is low risk drinking, 2 is medium, 3 is high, and 4 is very high. And what they found is that basically people at the low risk drinking level had recovery of brain volume that was comparable to abstainers in a small sample. And so this idea that drinking reductions are achievable, they're maintainable, they're maintained, and they're associated with improvement in function, I think really a sea change in our field. Forever, we've focused on abstinence as a primary endpoint for clinical trials. More recently, the % of subjects with no heavy drinking days. But again, that really is a limited endpoint in that someone could have one heavy drinking day and be a failure based on that endpoint. And so the idea that we could have these different risk levels, which might be very useful clinically, is also, I think, a sea change for our field. And I'm really excited about this work showing the validity of these risk levels. So I'm going to move now kind of and broaden this perspective back to recovery, and again note that recovery via abstinence is commendable and rightly celebrated as a successful pathway. But I'm going to ask the question with some new data I'll present on whether we can widen the focus to maybe include other pathways to recovery. And so I'm going to present this idea that the abstinence focus of the recovery movement could be at some cost for public health, and we're going to revisit this. But when we look at the National Survey Drug Use on Health, they ask about treatment seeking, and they ask about individuals who don't seek treatment, the reasons for that. And so what we know is that approximately 20% of individuals with alcohol use disorder seek treatment. And our data suggests that about 36% of those with alcohol use disorder in treatment who receive an evidence-based treatment achieve continuous abstinence. So that's about 7% of all individuals with alcohol use disorder are helped with a kind of abstinence frame. But 77% of those who seek treatment actually achieve significant drinking reductions. So if we think about achieving a significant drinking reduction as success, then 77% are succeeding. If we think of abstinence as success, only a third of people are succeeding. But for the 80% of individuals with alcohol use disorder who are currently not seeking treatment, about half of them say that they don't seek treatment because they don't want to abstain. They don't want to stop drinking completely. And in fact, a recent clinical trial that I ran that welcomed everyone, so we didn't require an abstinence goal, about 80% of people in the trial said they wanted to reduce their drinking. They didn't want to abstain. Only 20% who presented to treatment for our trial wanted to abstain completely. And so if we think about the total number of people with alcohol use disorder, if we could engage 50% of those individuals who weren't going to come to treatment in a drinking reduction treatment, we'd be helping about 40% of individuals with alcohol use disorder. So from a public health perspective, we go from 7% of those with an alcohol use disorder achieving abstinence successfully to 40% of individuals with alcohol use disorder who might engage in treatment if there were drinking reduction options. So then the question becomes, can individuals achieve and maintain a non-abstinent recovery? And I'm using recovery in quotes because I'm going to kind of expand our definition of recovery in these analyses. I'm going to be looking at data from Project Match, which is a very old study at this point. In fact, they were using DSM-3R at the time of the study, so that gives you a sense of the age of the study. Most people in Project Match met criteria for alcohol dependence from DSM-3R, and the other 10% met criteria for alcohol abuse. They were recruited from inpatient and community treatment programs and provided 12 weeks of behavioral treatment, including cognitive behavioral treatment, motivation enhancement, and 12-step facilitation. The outpatient sample that we'll be looking at with 3-year data was about 85% of the sample was retained for the 3-year follow-up. We'll also be looking at some 10-year follow-up data, which is 65% of those who consented to the 10-year follow-up, but it is a small number, only 146 for these long-term follow-ups. I'll also be looking at the combined study data, which included participants who met criteria for DSM-4 alcohol dependence. They were recruited from community treatment programs, given 16 weeks of treatment with a combination of medications, including acamprosate, naltrexone, or matched placebos, and a combined behavioral intervention. And the combined behavioral intervention included aspects of motivation enhancement, cognitive behavioral treatment, and 12-step facilitation. So it kind of combined all of those behavioral treatments. I'll be looking at mostly at those with 3-year data, which were recruited from the combined economic study. That's 694 people, 79% of those who consented. And then there's also a 7 to 9 year follow-up that was conducted in a limited set of participants. Again, about 64% of those who consented, in a small number again at this long-term follow-up. Okay, so how am I going to define recovery? Well, I wanted to basically take a more empirical or data-driven approach to defining recovery. And so I used a latent profile analysis, which is a very exploratory data-driven approach to parse out subgroups with similar responses to measures or similar responses to the indicators that I'm including in the model. And so I included post-treatment drinking as well as functioning to see if there's people who kind of subgroup together in different profiles of recovery at 3 years following treatment. So in Project Match, I included measures of psychosocial functioning and life satisfaction, included measures of unemployment and psychiatric symptoms, also included alcohol and other drug use and alcohol-related consequences. In Combine, I included measures of psychosocial functioning and quality of life, unemployment again, and then alcohol and other drug use. And so the idea with these models is we're going to put all of these measures into the model and then see how people kind of group together based on their responses to these measures. And I'll start with, we started with Project Match, so I'll start there. So we looked at these different measures in Project Match, and we found what seemed to be supported empirically was 4 profiles that could be distinguished by consumption and functioning in Project Match. And so I'll start with the big purple profile. That was the largest profile, about 51% of the sample. And we classified these individuals as high functioning and infrequent drinking. So on all of the measures of functioning, they were well above average and they were not engaging in much drinking. In fact, 49% of them were abstinent. So that was the biggest profile, which is great. So over half of people, even 3 years after treatment, are not engaging in much drinking and are very high functioning. So then I'm going to come to profile 1, which I think is the other more obvious profile. It is individuals who are not functioning well and they have returned to very heavy drinking. None of them were abstinent. And so this would kind of be if 51% of people are in a success profile of really, getting a lot out of treatment and continuing to be high functioning, then this profile 1, this 16% is kind of a failure profile. They did not do well. They're not functioning well, and they're engaging in very heavy drinking. So profile 2 and 3 are the very interesting ones that were not necessarily what we expected. Profile 2 was individuals who were very low functioning. In fact, they were functioning as low or lower than individuals in profile 1, but they weren't engaging in as much drinking. They had some heavy drinking occasions, but over a quarter of them were abstinent. And so they were not engaging in a ton of drinking, but they still didn't have very good functioning. And importantly, they reduced their drinking considerably from baseline. So they did kind of have success in treatment from a perspective of drinking reductions. Profile 3 is also a very interesting profile. These are individuals who are functioning as well as profile 4. So their functioning is really great and above average on all the metrics of functioning, but they're engaging in occasional heavy drinking, and occasional heavy drinking meaning about once a week, exceeding the heavy drinking limits of 4 or more drinks for women or 5 or more drinks for men. And none of them were abstinent. They did have significant and large reductions in their drinking from baseline. So many of them went from, for example, 15 drinks per day on average at baseline to about 6 drinks when they drank heavily. But importantly, most of their occasions of drinking were not heavy drinking. So they had about 70% of days were drinking days, only about 25% of days were heavy drinking days. So it's an interesting profile that these are individuals who seem to be very high functioning, engaging in some heavy drinking. And so I would kind of call them these kind of non-abstinent recovery, that they're not having a ton of drinking, but they're functioning really well and functioning as well as abstainers. So this was the profile analysis from the Project Match data. We then attempted to replicate this in the combined study data, and I did change the slide these are new data. It's just a completely different sample, but the same exact, almost the same exact findings were replicated. So we also find about 51% are high functioning infrequent drinkers, and about 14% now are kind of this failure group of low functioning heavy drinkers. And then again, a low functioning heavy drinking group and a high functioning heavy drinking group. So in both Project Match and Combine, we see that there appears to be kind of recovery that occurs via via abstinence or very low risk drinking, and recovery that appears to occur with occasional heavy drinking. So then the next question the reviewers always asked us, reasonably so, was, but what happens to these folks? Because the profile 3 people are just on a crash course to return to very heavy drinking. I think someone even said that in one of the reviews we got, that like these people are just doomed to fail eventually. And so fortunately, we have these long-term follow-up data. And so we've now published these 2 papers showing that actually these high functioning profiles maintain good functioning up to a decade following treatment of those who were followed in these longer term follow-ups. So the high functioning profiles in Project Match had significantly greater purpose in life. They had less depression, they had lower anger. And this just shows the purpose in life for the 4 profiles. And what we can see is that profile 3 and 4 are very similar in their purpose in life 10 years later. And I should say that these are the profiles determined at year 3. So 7 years later, the people who were classified in these profiles are still doing well on purpose in life. Profile 1 and 2 not doing as well, especially profile 2 on purpose in life. And then in Combine, we looked at individuals again in these profiles at 3 years. They were classified at 3 years. How are they doing 7 to 9 years later? And the high functioning profiles had higher self-reported health and fewer hospital stays. So this just shows the data for the health being self-reported as good to excellent. And we can see profile 3 and 4 again are doing similarly well with self-rated health. And again, profile 2 is really, really not doing that well. So we have these data now. We replicated in 2 different studies across long-term follow-ups, but ultimately, I became very interested in kind of who is in these profiles and how can we help translate this clinically to understand which of our patients might do better with low risk drinking or with non-abstinent recovery, and who might be more likely to fall into kind of this lower functioning category. And so we report on more outcomes in the papers. But I just wanted to focus on socio-demographic factors for a moment. And so what we found in Project Match is that younger age predicted a significant probability of being in one of the higher functioning profiles, and that individuals who are non-Hispanic and white had greater odds of membership in profile 3, this high functioning, occasional heavy drinking profile, versus those in profile 4. And then in Combine, we see males have greater odds of expected membership in profiles 2 and 4 and not in 3. Older individuals have a higher expected membership in profile 3, and married individuals have a greater probability of membership in profile 4. And then again, we find that individuals who are non-Hispanic and white had greater odds of membership in profile 3 compared to all profiles. And so this is now replicating in 2 different studies showing that there's something about being non-Hispanic and white that is supporting this non-abstinent recovery. And of course, what we know is that race is meaningless, right? It's a social construct. And so what we know is that this indicates there are systemic factors that are influencing the ability of people who are not Hispanic and white in these studies to maintain high functioning heavy drinking. And so in our latest work, we've zoomed out to look at study site as a proxy for community level variables. And so we've been thinking about how could community level and specifically community level economic factors be supporting people in non-abstinent recovery. And what we found is that, and this is work that's led by my graduate student, Julia Swan, that the high functioning heavy drinkers, so the probability of being in profile 3 is directly related to income inequality in the community. So individuals in places with lower income inequality have a higher probability of being in a high functioning profile. And then we also saw a main effect of health insurance. So individuals who have the communities with greater health insurance are supporting people who have a higher probability of being in the high functioning, heavy drinking profile. So it's not being non-Hispanic and white that is supporting people in a high functioning drinking pathway. It's living in communities with lower income inequality and living in communities with more insurance and more income and more community supports potentially that is supporting people in achieving a high functioning non-abstinent recovery. So kind of zooming out to what does all of this mean? Well, I hope it sheds some light on thinking about recovery. And I want to jump back to the epidemiological data to remind us that most individuals with alcohol use disorder are not severe and are not coming to treatment. They don't want to come to treatment because they don't want to abstain. Recovery of functioning well-being and quality of life is possible among those with alcohol use disorders, and abstinence may not be required to achieve those recovery outcomes. Community level economic factors are also really important in supporting recovery. And so I think the abstinence focus of our society and also most treatment programs, we see it as a barrier to treatment seeking. Many treatment seekers actually have drinking reduction goals. But I want to come down to actually, I think, a bigger point of this work that we're coming to by looking at these community level data in particular, is that if we target a broader definition of recovery, it puts the focus on healing the whole person, providing support for the whole person, and not just eliminating alcohol and drug use. If we think about our current treatment programs that really focus on just eliminating alcohol and drug use, we get the person to abstinent, but then what happens? And what community are they in when they're abstinent? And how is that community supporting them? And how about their mental health? And how about their stress? And how about their ability to find work and their ability to provide for themselves and have a home and safety? And so I think there's a bigger picture here beyond just extending definitions to include non-abstinence. It's also about how we think about how we can treat and help people with alcohol use disorder. So by shifting the attention from targeting individual alcohol use to examining and targeting the fundamental causes of alcohol use disorder and conditions that will actually support recovery. And so, I mean, really coming back to Maslow's hierarchy of needs and making sure that we are not just getting people to abstinent, but also supporting their basic needs and their psychological needs. And I'm going to share, and that's why there's this little pop-up here. Sorry about that. It's coming soon. I'm about to show you a significant chi-square. But anyway, so I did a study several years ago. It's actually one of my favorite studies I've ever done. We did a randomized clinical trial of mindfulness-based relapse prevention as compared to relapse prevention within a residential program for women with substance use disorders who were legally involved, who were part of the criminal legal system and were able to go to treatment instead of prison. And so this was the facility where we were working. And so it was a 6-month residential treatment program, abstinence-based, focused on all substance use disorder, all comers. And so we did a clinical trial. And one of the outcomes that we looked at, which I'm glad we collected from the center, was their discharge status. And what we found is that individuals in mindfulness-based relapse prevention, none of them were discharged to the street or to their car. So none of them were discharged to being unhoused. Whereas in the relapse prevention condition, I think it was six women altogether, were discharged to being unhoused. So relapse prevention focuses on getting people to abstinence and keeping them there. Mindfulness-based relapse prevention, actually, we don't really talk about alcohol use or substance use much at all. We talk about reactivity, we talk about how you're experiencing your world, your relationship with your world, your relationship with others. but it's not the sole focus. So targeting alcohol use or substance use is not the only focus. Relapse prevention, that is the big focus. I mean, we also talk about coping skills and various things, but the focus is on not drinking. And when we look at the discharge status, this is reflected there that people were discharged to being unhoused and really not having those basic needs met. And so I'm going to quickly shift into a mindfulness exercise that we do in mindfulness-based relapse prevention to try to drive this point home a little bit further, if I can forward this. So if you're willing to play along, and this won't be very long, but if you could just maybe close your eyes if they're open, or at least just kind of mindfully attune to the practice, or mindfully kind of come into yourself. And I want you to imagine something that you do that you don't love that you do, some sort of reactive behavior. Maybe it's substance use, maybe it's eating related, maybe it's watching TV or looking at your phone or putting on the news or checking social media. Something that you do that you don't love that you do it. It's kind of a reactive behavior, kind of do it automatically. So I really want you to think about this situation, imagine yourself about to do this thing that you do. I keep going like this because my thing is like looking at my phone and seeing email or whatever news is new. And just ask yourself the question, what are you really seeking when you engage in that behavior? What are you really looking for? And so I'll let you sit with that question for a moment. What are you really looking for? And I won't make you ask, and this isn't really a great format or I won't make you answer, and this isn't really a great format for doing this, but I will say that when I do this live and with students or with classrooms, we hear a lot of different things that people share. Some people are looking for relief from pain or boredom or depression. Some people are looking for social connection. Some people are looking to feel joy or have fun. Some people are looking to be numb or to get away. I don't know if any of these roughly identify with maybe what you've been seeking in this behavior. And when we ask the same question in our mindfulness-based relapse prevention groups, these are the same things that people share with us as why they're engaging in substance use behavior. And when I look at these, I see really wholesome human needs that people are looking for. And maybe they're getting it at times, but it's kind of what we call a false refuge. It doesn't really provide what we want it to provide all of the time. Maybe it does some of the time, but it isn't reliably providing these things that we're seeking. But what we're seeking is actually really wholesome. And how else could we possibly achieve these things? How else could we possibly build a life that has components that give us social connection, that let us feel joy, that bring us relief, to let us get away, that might be not involving substances, or maybe involving substances but less substance use, if that's our choice. So I think this exercise is really to get at the point that people who have substance use disorders are seeking to fulfill basic human needs. And what if we could reframe substance use disorder and recovery broadly with that in mind? And what if we could potentially then depathologize substance use, destigmatize substance use, and more so shift from a pathology-based model of alcohol and substance use disorder to more of a strengths-based approach and more of a holistic approach that's really recognizing this whole person who has the causes and conditions that led them to substance use in the first place, and maybe addressing those, not just eliminating the substance use. I also think requiring abstinence in definitions of recovery perpetuates this kind of us versus them stigma of alcohol use disorder, where I can drink as much as I want as long as I don't have an alcohol use disorder. But if I have an alcohol use disorder, then I can never drink again. And that is really prevalent in our society. I don't know if you've noticed that in media portrayals, but it's very common. And then I think the biggest point is that eliminating substance use may not address the causes and conditions that led to the disorder. And so taking a broader focus on recovery requires us to care about targeting the whole person, and maybe requires treatment programs to start focusing on not discharging people to being unhoused, to focus on helping people connect with recovery supports in their community, because it's not just about getting them to abstinent, it's about supporting whole person recovery. And then finally, I want to come back to these findings of social determinants of health and culturally how we are targeting alcohol treatment generally. And I think we need to develop and disseminate culturally centered treatments that target drinking reduction. We need to think about how the impact of a non-abstinent model might reduce stigma and increase access to care, maybe increase desire for treatment seeking, making treatment more focused on whole person recovery and not just about this one behavior that is stigmatized and pathologized. And then also along all of this, when we're doing this work, we need to be doing this to actively work to eliminate racial and ethnic inequities, systemic racism, barriers to wellness in the community, as well as these other social determinants of health, income inequality and insurance status and ability to apply for jobs and get jobs. There's gross racial and ethnic inequities in these. And so we need to be addressing these as we move forward. And I also think we need to be thinking about expanding access and services to focus on the broader communities. We need to be meeting people where they're at and taking a more socio-ecological frame in thinking about recovery and not being so fixated on fixing the individual. The individual is not the problem. The individual is emblematic of broader societal problems. And so I just highlight a couple of recent papers that I think do a really nice job of this. Susan Collins and Seema Cliffeseffi and others at the University of Washington have done great community-based participatory research on looking at harm reduction treatment for people experiencing homelessness and in chronic alcohol use disorder, and showing that people who even don't want treatment are willing to take extended release naltrexone, and it reduces their harm. And then Ayana Jordan did this amazing and is continuing this with an R01 amazing study on bringing treatment to a Black church and providing substance use treatment in that context, meeting people where they're at, literally coming to them. And I just love that work. And finally, I just want to call out related to this that we have a special issue of Psychology of Addictive Behaviors that there's currently a call for. As Warren mentioned, I'm editor of Psychoaddictive Behaviors. And this special issue is going to be guest edited by Geely Tucker, Joanna Buscemi, Jim Murphy, and Derek Reed. And it's going to be focused on addictive behavior as behavioral allocation. And it's really in honor of Howard Rachlin and his work on behavioral economics and molar behavioral approaches, and in particular, papers that contextualize choice behavior within broader community and policy environments will be given favorable consideration. So please do check out this website and submit your papers by February 15th of 2022. And so with that, I just want to thank my many trainees over the years. And here's a little advertisement for coming to New Mexico. These are both, this is actually behind my house right here. We did a pandemic hike behind my house, and this is just about a couple miles away. So advertisement to come to Albuquerque. And I couldn't do this work without my great students and trainees, and of course funding. So, and thanks to all of you. I really appreciate being here.
Thank you, Katie. We appreciate that wonderful talk. I'm going to take the prerogative and start with one question, if I might. So the broad societal changes that can influence people's substance use and their pathways to recovery. Well, we've been experiencing one for 18 months, and I wonder if you might reflect on how that might be impacting individuals as they deal with their substance use disorder and their recovery from it.
Yeah, no, and I mean, we've been getting a lot of COVID papers at Psychoaddictive Behaviors, so there's actually a lot of great research coming out on this topic, and I think the pandemic has exacerbated these problems, particularly in racial and ethnic, historically marginalized groups. and so has exacerbated inequities. And so that's a big concern of mine. I think the bright spot of the pandemic in some ways is there has been increased access and utilization of telesupport services, and showing us that we can do these interventions or do recovery support via telehealth has been, I think, really, really helpful. And there's great work showing that actually a lot of people are engaging in recovery telehealth. And I know for our treatment clinic, we are now reaching areas of New Mexico who would have never been able to get services from us because we're doing everything via telehealth. And so we have people from all corners of New Mexico, which is a very rural state with very high alcohol mortality rates, and they would not have been able to come into the clinic in Albuquerque. And so I think the probably only bright side of the pandemic is showing us that there's this possibility of reaching people via telehealth. I think the other big issue in the pandemic is we've seen an alarming increase in drinking, particularly among women, and particularly among women who are dealing with a lot of stressors. And so I think we're going to see a potential increase in people needing treatment for alcohol use disorder. It's really interesting. I don't know what's going to happen as far as, if life ever gets back to normal. Do people go back to their old behavior patterns and kind of the alcohol doesn't become as much of an issue or not? I think that's something to be seen yet. I do think now is a time, though, to be kind of really putting out there these opportunities of non-abstinent drinking reduction options for people who's maybe their drinking ticked up during the pandemic. They're not really happy with their relationship with alcohol right now, and they'd love to maybe reduce their drinking again. And so having those services available, I think like the iron's really hot to strike right now. So I hope that answers that. But
yes, thank you. Anthony Lamancha asks, he's curious about male-female differences, and I think he's referring to the number of drinks that are for the different levels. And he's wondering, is the averages and differences not only due to body mass differences?
Yeah, no, it's a great question. Yeah, so the sex-specific guidelines are actually based on a lot of things, but one of the big ones is just women metabolize alcohol slower. And so less alcohol is actually more toxic for women. And that's actually another reason why the increase in drinking among women is particularly concerning right now, because we know that there's more harm at the same level of drinking for women. And so it's sex specific because basically less alcohol is more risky for women. And that's due to both differences in alcohol metabolization, but also I believe it's the difference of water to fat in the body as well. But bigger picture, women metabolize alcohol slower, and so less alcohol is more damage.
Something that we've been encountering in the lab that has puzzled us is because we have an alcohol bar, laboratory bar, and a transgendered person comes.
Mm.
Do you have any immediate suggestions about that? As they currently identify, or their birth?
Yeah, I would say, given the known biological sex differences in alcohol ability to metabolize alcohol, I would lean towards, and I'm not an expert in this area, but I think it's a really great question, but I would lean towards sex identified at birth. That said, I think it's a really great empirical question and one that needs to be dealt with by the field.
Sure. We have an anonymous attendee who asks, is it possible to convince someone to reduce their risk, or is that a choice they need to make for themselves?
Ah, that's fabulous. Thank you. I get asked that question a lot, particularly by concerned family members and friends who are concerned about a loved one. what we know is that self-determination is important. And so individuals wanting to make a reduction in their drinking for themselves is an important piece of the process. Now, that said, I think there is more and less helpful ways of working with a person who, so it's not so much convincing them they need to make a change for themselves. It's more of supporting them in looking at their relationship with alcohol and how it's serving them. I take a very kind of individualistic, holistic approach to this, that there are people out there who alcohol is serving them and they don't mind their relationship with alcohol and it's not causing problems in their life. But if it's causing problems in a relationship, then that's something to look at, right? And how is alcohol interfering with that relationship? And so that's something to talk to a person about. And so it's not so much convincing them, but really kind of asking questions in an open-ended and in what we would say motivational interviewing, consistent way of talking with them about their alcohol use and how it's serving them and its relationship. But I don't think it's helpful to say you need to stop drinking and like try to convince people. I don't think we know that that's not as effective.
We're just about time. I'm just going to select one more question, though there is a couple more, but we're just out of time. Anthony again asked a question about susceptibility factors, biological, genetic, social, for the 11% who develop alcohol use disorders. Is there a way to differentiate the different factors as they relate to the outcome?
Oh, go ahead.
And the idea of non-abstinence prevention for those at risk versus post-disorder intervention.
Yeah, no, I think it's a great question. And so I think the other downside of an abstinence-only model is most people don't come to treatment until they're very severe, right? And have already done a ton of damage to their liver and to other body organs. And so I think a non-abstinence model might aid in prevention by giving people resources sooner to help them reduce their drinking before they become more severe. That said, I do think, I don't think we know all the susceptibility factors. We certainly know there's a genetic component, there's a neurobiological component, there's a social component. And so it could be the case that someday we'll identify those people for whom abstinence is the only choice, and those people for whom drinking reduction is a very viable outcome. I think we're not there yet. But I do think all of this work, I also think of in a prevention frame, and that's where the public health messaging comes in, that really it would be ideal to prevent severe alcohol use disorder from ever developing. And no one wants to develop a severe alcohol use disorder that I've met, right? And so I think having skills and tools available and making drinking reduction socially acceptable, making the idea that you don't drink socially acceptable, I think would go a long way in helping with that message.
Katie, thank you so much for a wonderful talk, and we appreciate you taking the time to be with us.
Thank you. Thanks for having me.
Bye-bye.
Bye-bye. I love that clapping.
It was real. It was real.
That's so cool. That's my first virtual talk that had that. That was awesome.
Yeah, most people are flabbergasted by that. They're so used to virtual silence all these days. So. Anyway, Katie, that was great. Thanks very much. I look forward to talking to you a little bit later. Thanks again.
That sounds good. Great. So I'll just go to my own Zoom room next.
Yeah, I think so. Right.
Okay, great. Thanks. Bye-bye.